Good morning, everyone, and welcome to our monthly peripheral endovascular session from Mount Sinai, New York. This is Vishal Kapoor, your moderator for the day, and we just wanted to welcome you again this morning at 8 o'clock Eastern Standard Time for another exciting case from our cath lab headed by Dr. Krishnan. Before we head to the cath lab, just wanted to update you, our regular viewers, who know that our annual peripheral endovascular conference, which is usually held in June, of every year because of COVID reasons and has been rebranded as New York Endovascular Society Summit, has been scheduled for this year in October. The main session will be on October 15th and 16th. Please do look in for our website to get further details, including the agenda, the faculty, and further the information you might need. And it will be preceded by our famous Endovascular Fellows course, which will be on the 14th, headed by Dr. Krishnan and me and Dr. Guja and other partners, hoping to provide all the education to them. So without further ado, good morning, PK.
Morning, how are you guys? We have a really fantastic case here for you. We're just trying to get this sheath into the internal iliac. No, I don't want that wire. So what we're going to do is, before we start, I want to introduce everyone here. To my right, we have Dr. Karthik Guja, who's the Associate Director of our program. To right behind him and to his right, we have Dr. Ajit Rao, who is the Director of Vascular Surgery Research, as well as a really good friend and an incredibly talented vascular surgeon here at Sinai. And we have Dr. Raman Sharma, who's our endovascular fellow this year, and along with Dr. Sri Avadani. And we have Ray Lascano behind me, Tepson, who's our tech, Habib, who's our tech, and we have Elizabeth, who's our nurse as well. So we have a really fantastic case that, as we're doing this, I'm going to have Raman go ahead and present the case. So as we're getting things ready here, go ahead, Raman. You want to start?
All right. Thank you for joining us.
So I'm in a little branch going down.
Okay, so today we're going to be just discussing a very interesting case of the endovascular management of a severely symptomatic interiliac AVF.
Yeah, see if it goes.
So this is a 63-year-old female. She has a past medical history of coronary artery disease with previous PCI. Also a history notable for hypertension, hyperlipidemia, recent COVID-19 infection. It was mild. She did not require any hospitalization. And she presents with worsening shortness of breath with a new exercise tolerance that was decreased to now 2 to 3 blocks. She's on medical therapy. She had an exercise stress test that revealed EKG changes at a very low workload. She had a subsequent transthoracic echocardiogram that showed a hyperdynamic LV and no significant valvular pathology. Because of her stress test and symptoms, she ended up getting a catheterization, and the initial axis angiogram revealed this interesting finding. It was a little confusing at first, but subsequent imaging had revealed that there was something actually significant there, which I'll show in a moment. In this intervention, about 6-7 months ago, she was found to have an FFR positive LAD with an FR of 0.81, and she underwent successful balloon and DES implantation. She had an elevated EDP of about 22 at the time as well. Afterwards, once they finished up the intervention, they tried to investigate what exactly was happening in that initial shot, and they had this DSA imaging that showed this internal iliac AVF, quite large. A subsequent CT. Do you want to show do we have the CT that we can actually put up now? Yeah, 1 second. So here we're looking at the coronal CT, and we're scrolling anteriorly, and you're seeing at the left of the screen. Let's go all the way posterior, and then we can come back forward. Okay, good. Okay, so now we're coming up, and you see to the bottom left as the internal iliac is coming up. Maybe someone can point it with a pointer. The malformations that we're seeing of the right internal iliac as it's right before the confluence into the common iliac artery on the right-hand side. So you can see this very significant and impressive AVF malformation. Let's see, let's go back to the slides. Or do we have the axial imaging as well? Okay, 1 second. Good. So now we're starting at the base of the heart. And this is a CTA imaging, and it's important to notice that one of the first telltale signs is that as a CTA, you expect that just the arterial phase would result in arterial contrast enhancement, but you see the IVC to the left of the distal abdominal aorta is already filling with contrast. That's not the common iliac. The aorta bifurcates right about here, and as you see, you already see the iliac vein already filled with contrast. So at this level of the bifurcation, you see that the right common iliac artery already has a connection to one of the arteriovenous with the AVF. And we see that these multiple, several areas of connections to the fistulas, to the veins, quite pronounced as well. All right, so now we can go to the next slide. So this is just still frames of everything that we had just seen. So you can see in the coronal imaging on the left a nice still shot of what we'll show quite nicely in the angiogram in a moment, as well as what we see in the axial imaging. So we see multiple venous connections from the right internal iliac artery. So because of this, several months later after being on the medical therapy, she continued to have severe symptoms of shortness of breath and signs of heart failure. So the plan for today is to do a percutaneous closure of the right internal artery AVFs with vascular plugs and or coils as needed. Like I said, now we can put the angiogram back on.
Okay, well, thank you again, Raman. I mean, so Ajit, I mean, and Karthik, here you have a lady who's had shortness of breath, was very symptomatic, as you saw, had a stress test by one of our colleagues, had a stent. At that time, they actually explained why she was so short of breath by looking at this fistula. And she's now had, I spoke to the doctor yesterday prior to letting him know we were bringing her in today. She's also had a drop in her EF. I don't know if Raman noted that. I forgot to tell him. Which again is very important, but I decided to leave that out for him just to make it more interesting. So the question now is, as far as we're concerned, what is it that we're going to be able to do for this? So Ajit, I mean, obviously the majority of our audience is cardiologists, and we're really are grateful that you're here to help us understand this, how to deal with this, and how to use some of these novel devices such as coils and plugs to be able to fix these lesions. So can you go through a step-by-step in terms of how you would approach this? What is the appropriate workup? I know Raman went through some of that, but what are some of the things that you would suggest? No, it's fine. That's fine.
Yeah, of course. Pretty good. So thanks again for inviting me. I'm happy to be here. In terms of the malformations,
I'm trying to find it now.
The first thing, I guess, when you look at it is you want to see what kind of malformation it is. So there's different kinds. There's high flow, low flow, and that matters because of the treatments you would use. So in this case, this is a high flow malformation because it's arteriovenous malformation that's, of course, causing hemodynamic changes. So that's important because certain treatments can, embolize, and, in terms of what the symptoms that they can cause, one of them is heart failure, which is, what happened in this patient. So in terms of the workup, I think a MRA or a CTA is typically what I like to get. If it's in the extremity, I can also consider a duplex, because then you can really look at the hemodynamics. Yeah, that's good. But I would say ultimately I end up getting a CTA or MRA for these kinds of lesions. Is that similar to what you guys do?
Yep. So that's similar to what we do. So what we decided to do here is we had a very good angiogram by our colleague, and our colleague went ahead and showed us that there was a massive high flow AV fistula. So we decided here to get a CTA, CTV to really try to reconstruct, which Raman just showed. Problem, as you thought, was there was a lot of tortuosity with the collateral, with these AV malformations, and that's why we decided to bring him for angio. I mean, I want everybody out there to know that we're flying through what we're seeing here, because it was very difficult to plan this case with the CT. We're trying to now interrogate this, understand it, which I think will be very useful for the audience to see how to approach this. So, Ajit, our plan was just to do a CT and bring him here. So just for the equipment-wise, everyone, we had an 8 French up and over. Can you go scene minus, Raman? So we did a venogram, which Raman will show you minus. and no, the first one. We did a venogram to really demonstrate this. That's the one. I think that's the one. Just go to the first one. So we did a venogram to demonstrate, there it is, to demonstrate the malformation. You can see it's quite extensive. And then you can see the IVC light right up through the internal iliac vein. Next. So then we were able to cannulate, Vishal, the internal iliac artery, which we believe is the connecting source.
Right.
We used a Berenstein catheter with a woolly wire, and then we tracked the 8 French sheath with some great trepidation and difficulty through it after burying the wire deep in the malformation. And now what we're trying to do is find the actual feeding vessel, right? And so so right now I've got a Berenstein catheter. We were attached. Karthik and I got into something. I don't think it's it, but we're going to give a little dye here to see what it is. Yeah, well, let's just do a short DSA. Yeah, so we got to watch our pressures as we inject here. Okay.
Yeah, I think the biggest factor is identifying that feeding vessel, because you're right. There are multiple pockets of AV fistula, but identifying
that's the internal
vessel,
right?
Yeah.
So that's not it. So we're trying to figure this out here. Which Ajit and I saw a large vessel, but I'm unable to see whether we can find it. Little dye here, Karthik. There it is. I thought that was it, but it's not finding it. So might need a coronary wire, like Karthik was suggesting, to try to find it.
Give me a fielder, guys.
Ajit, do you think that's it right there?
Yeah, try that.
It's hard to tell.
It's hard to tell. I also see like a very straight branch that goes down.
You like that one too?
Yes.
Yeah, we could try that one too.
Okay.
Yeah, that goes kind of straight distal.
Yep. That one's easy to get into for
But
sure.
yeah, no, this is definitely a very complex one. There may not be just one. This is often the case. It may not be one connection, and especially when you get some of these more complex arteriovenous malformations, they often do require multiple treatments over years and years. But I think the goal here is kind of what we recommended is, and the other thing to mention is what we're treating, which is, we're trying to make this, get rid of the high flow state here, since she's having heart failure symptoms. So really finding the inflow is going to be important.
It's going to be really important.
And the first step.
And again, to everybody at home, it's almost like a trial and an error. One of the things that I know that some of the newer machines, even though this is one of our newer machines, we don't do a lot of these malformations here, is they have a CT that you can actually overlay on this. Have you used those kind of machines?
I used to use them when back when I trained, especially for some oncology cases. They would use it for like the liver embolizations. And that definitely can help you in situations like this where you can get
go down and try one of the other branches.
Where you need to go and what wire, artery you need to navigate. So I do think there is some utility in using that. Hopefully here I only see a couple of branches, so I think we'll be able to find it just fine without it.
Yeah, I think there's a branch coming just posterior to it where you can actually try to feed it.
Well, I think what Dr. Rao is saying is probably right, is go with the large one and let's cannulate that and then take a picture. So Karthik and I were just talking offline on which wire to go with. So we decided to just go with a larger woolly wire and try to just steer it into that large branch and see if that is the true communication for the fistula. Now look, I got into the smaller one. Yeah. Let's see this one now. I knew I was going to get in. Karthik kept saying no, but I knew. Karthik was like, no, pre-care, you're not getting in. I'm like, I'm going to get you in. All right, let's see.
Give me some dye.
I may be wrong.
No, you can hand inject.
Give me some hand injection dye, guys. All right, let's take a picture here. Again, we're multiple minds are better than one, that's for sure.
The back end.
I think that vessel, the one which is going straight down is
We're back in the same vessel, right?
You have to come back to the vessel which is going down. So come back to the
now I see it. Yeah. Absolutely.
And I think the other ways, which I guess, which I agree with Karthik, is instead of, because it's such a complex AV fistula with multiple pockets, the other thing you can do is just take a wire and try to wire around it and see if it connects. You know how you find a micro channel when you're doing CTOs? You could probably use a wire and try to fish around and see how the wire behaves and if it connects. If any of those channels connect, that becomes at least one of your AV fistula channels which could be corrected or fixed.
Well, I think personally, Ajit, that it's going to be what you said. We're going to close one and then we're going to evaluate, and you're going to see that, well, this one opens up. Let's do this one. And we're going to chase this a little bit for a little while. And then we're going to be able to get in. So let me pull this back here.
Yeah, I guess.
That one.
Just a quick question. Does the anatomy of the left internal have any bearing on the treatment of the right side?
Yeah, this is it.
Yeah, no, I definitely think that's important to consider. I think your internals and even your IMA in some cases, because the, for a couple of reasons. So number one is we often embolize the internal iliacs when we're treating complex aneurysms.
Correct, right.
And one of the, sequelae can be like buttock claudication. So certainly if they have their other internal iliac open, that can kind of decrease that risk. But more importantly is pelvic ischemia. So thankfully that's very, very rare. And oftentimes we embolize both internal iliacs, and besides some claudication, patients do just fine. So this patient thankfully has, both internals open and is like not a vascular path. So, I think
that's
we tolerate the embolization of the internal just fine if we needed to. But I think trying to select the branch is obviously going to minimize that.
All right. So we got the big one here.
Yeah. Can I just pause it? Oh, yeah.
Yeah, and so this is the largest one.
Yeah.
That's the largest one.
So the question is how far down you want to go now. So one of the things that Dr. Rao and I myself were talking about is, how far distal do you want to get? Because as you were saying yesterday, that you could actually burn a bridge to doing something. The question here is this turn is so acute that I had to pull the Bernstein back because it got kinked. So I don't know if the coils will go through that. Yeah, so that's another question.
Yeah, so I think this is a pretty interesting spot to stop because we have a lot of options potentially. I think if we do use, especially some of the, a prograde or a micro catheter, I think they're going to track through that just fine. So that's one option. We talked about using a plug. I think that might be something we should do on the way out.
Exactly. Coil first, distal, and then plug it at the main stalk.
Right. And then last thing is like not burning bridges. So I think trying to go as distal as we can, as long as we're being safe, will help us, because if we ever need to come back, it leaves a channel for us. So
question in terms of IVUS, would you do IVUS sizing? How do you size?
I think IVUS is not a bad idea if you want to do it. And if
we don't have to do it. I'm just asking.
But I think, looking at the CAT scan, we can get a pretty good estimate of, what size these vessels are.
So right now what I'm going to try to do is put a 014 coronary wire as far as I can. And then what we're going to try to do is track up. We have Renegade catheters. What do you suggest? What do you use?
Renegade's good, or Prograde is what I'm more familiar with.
Do you have that? You have a Prograde with you?
We have a Prograde.
So can you tell us a little bit about this Prograde catheter? Give me a run through, wire chief.
Ajit, question is, if you put coils before and plug later, right? Do you think it will be enough, or you think first plug it and see how it does and then throw the coils in? Because progression of the coils forward is much more.
I hear you.
Right? So
the only thing is I don't know if our plug will track that far in.
Exactly.
I don't know if it's going to take all those bends. The coils will have a much easier time.
Okay, so that's what you're saying.
So this is a good moment to stop and let Raman. Raman has done a great job, like Shreya does usually, to go ahead and make a presentation. Obviously, I just want to tell everybody this is not something that Raman or myself or Karthik do on a regular basis, or Vishal. But however, it's important for interventional cardiologists to understand coils, especially if you're going to do endo. So Raman, if you could kindly go through your presentation.
Yeah, for sure. So let's see if you go back to the slides, please.
Roadmap this and then
okay.
Yeah, of course.
So what we're basically going to be talking about now is kind of just the brief lay of the land of the devices available. I'll be talking mostly about plugs and coils, and Dr. Rao, if you have anything you want to add as I'm moving along, please feel free to finish my sentences for me. So first, we're going to talk about the three Amplatzer vascular plugs that are available in the U.S. So there's AVP 1, 2, and 4 is a 3 that's not available here. But the first one is the AVP. It's one of the first ones. It's a single lobe and a single layer nitinol mesh. And they basically have platinum bands on both ends. And generally for all these, you want to choose a device that's about 30 to 50% larger in diameter to the reference vessel. And this one in particular is quite good for times where you have a very short landing zone. See some images of what this looks like on the right. The one on the left is an image of what it looks like fully unconstrained. There are two dimensions you have to think about. The one is the unrestrained diameter, and then the unrestrained length. And obviously, depending on the diameter of the said vessel, that will determine the length of the eventual complete deployment. Obviously, like everything we do, everything has a very particular type of dimensions that have to be respected when choosing the devices that we're going to be using in the case. So there are vessels that can be treated from 2.5 to nearly 13 millimeters, and all these, as the devices get bigger and bigger, will require larger sheets and or guides, depending on how we choose to do the delivery. Let's see. The next generation was the AVP2. The main difference between the AVP and the AVP2 and 4 is the fact that AVP1, if you remember, it's a single layer, single lobe nitinol mesh. These, the 2 and 4, are multi-layer interwoven nitinol meshes, and the 2 and 4 are both tri-lobed. Sorry, they're multiple interwoven. The AVP2 is a tri-lobed mesh. So what that means is that if you look at the image on the right, when it is fully expanded, there are 3 individual lobes. And this then, by just mathematics, results in 6 planes of cross-sectional coverage. And the idea is that this results in a more rapid occlusion of the target vessel. And this is also very good for when there are multiple varying landing zones in the respective vessel. And again, yeah, I mean, these are just details that when you're sizing for the procedure, you should just keep note of. Generally speaking, an 8 French system should be definitely good enough to deliver almost any device that you're willing to or need to. The last one is the AVP4. This is, again, a multi-layer interwoven nitinol mesh, but this time instead of 3 lobes, it's only 2. The other interesting thing about this is that this is a lower profile, and it's actually compatible with an 038 guide wire diagnostic catheter. So in a situation like this, where we have a 5 French catheter inside the vessel, this coil can actually, this plug can actually be delivered through there. So this allows for more distal delivery of the plug, as well as very distal and through very tortuous anatomy, which in this particular case may not be a bad solution. And again, you have the sizes that have to be considered. One thing to remember as well, since this can be delivered through a 5 French diagnostic catheter system, the maximum diameter of the vessel that it can be treated sometimes or in general, is a little bit smaller than the rest of the AVP1 and 2. The next one we have is the MVP microvascular plug system. This is a little bit different. It's a PTFE covered plug system, and this is actually the first plug system that actually is able to be delivered through a microcatheter. So that means that you can have vessels that are as small as 1.5 millimeters, and these can actually be successfully treated. So we have a little video after this slide. So this is a diagram showing that what the 4 different MVP sizes and what the reference size of the vessel that they can be treated. The MVP 3 and 5 treat quite small vessels, so their use in this particular case may be limited. But the 7 and 9, which are bigger ones, can be considered. And again, they can be delivered through a diagnostic catheter. A 5 French should be more than enough. So we have a little video. This delivery system is pretty consistent for the AVP1, 2, and the MVP. The only difference between this and the AVP4 is the fact that you would have a diagnostic catheter as a part of your delivery system. There's no audio, but...
So you can talk them through it.
Yeah, so we have access into the desired vessel for occlusion with the appropriate guide wire. And a guide sheath, and the device comes in preloaded into a covered system, and it is uncovered and expanded within the actual desired vessel. And once the appropriate angiogram is performed to show that it's where it should be, it can either be unscrewed or depending on the system, one is a screwing, the other is one of the other ones can be a ball and socket removal for coils, and we'll look at that. And then the device is then left in the appropriate place. Yeah. Then we're just going to talk about some of the coils. Do you want to pause for a second? Or?
Yeah, you can pause for a second. I think that's good. I just want to tell the audience what we've done so far. So if you look at the image here, The key here is it's basically a triaxial system, I guess the way to put it. The first thing we did was we put an 014 coronary wire distal into the AV fistula as far as we could. Then we couldn't track our Bernstein catheter any further, so we decided to go with this wonderful Terumo catheter called the Prograde, sorry. So the Prograde catheter tracked all the way through, as you can see, and then we were able to track the Bernstein over it a little bit. Now we've got an 8 French sheath into our what is it called, internal iliac, a Bernstein into the AV malformation, and a Prograde very distal in the AV malformation. At this stage, we pulled out the 014 wire. ACT is around 260, and Dr. Rao is going to talk a little bit about the coils, and then we'll have Raman finish so we can keep going with the case. So what coil did you decide on?
So this is we decided on the Terumo coil, and we're going to use a 14 millimeter coil to start. We measured the vessel at about 10 to 12, so we want to oversize it a little bit to make sure it sits well and it doesn't move. Okay.
Now, would you take a picture distally through this catheter, make sure of anything? Are you worried about anything?
Yeah, it'd be nice to see kind of what it looks like distally.
So Karthik is going to, I'm just going to hold the system in place while Karthik takes a little picture.
PK, so there's a question from one of the audience. Do you use, and are we using anticoagulation in this case? And if it is, what are we using?
Yeah, we used heparin. I mean, the reason I used heparin, no, but just do a DSA so we can document it. I used heparin because, you know, I don't know. I can't see anything here, obviously. Yeah, you're not going to be able to see much here, Ajit. We used heparin here. Okay. Can we do it again?
Yeah, or we can do it more proximally, you know, just to see what it looks like. Make sure we're not too far.
Okay, inject from this one then.
Yeah.
Yeah, the main sheet. Yeah, so Ajit, about anticoagulation, there's a question on anticoagulation in these cases. What do you think about that?
I think it looks good. I just want to make sure.
I think that's the distal most you can actually reach with that catheter.
I could inject. I could pull out. Yeah, we're truly in that little fistula right there.
Yeah.
Yeah.
Right. Yeah, we could even pull the Prograde back like a couple of millimeters.
Back, right? Yeah, that's what I thought.
But yeah, otherwise it looks great.
Pull back
in terms of anticoagulation, I think it's reasonable. You know, this isn't like a bleed or anything like that, so you don't need it to clot off, you know, right away. You can, and the last thing you want is to have access issues or anything like that. So I think anticoagulating is a good idea in these cases.
Go ahead, inject. Aman. That's reasonable. That's good.
Okay,
that's good.
That's it.
Now you inject.
You can't inject much through that microcatheter.
Okay.
Yeah. I think that looks like a good spot.
So Ajit, then averagely for coils 20% above the vessel size, you want to go?
Yeah, generally about like 1 to 2 millimeters above sufficient. I think every company has their own.
Let's go ahead. Ajit is going to go ahead and deploy it.
So so these are the Terumo coils. These ones I like because they're detachable, so you can basically pull them back and seat them however you want.
It to them?
And so once you have it in a position you like, I don't know if you can see, but this is the device that goes at the end, and that's what you place, and you push this this button right here, and that will detach the coil. So I like these because you get a lot of control with them, which is important when you're trying to really precisely deploy them.
There you go. I'm just holding everything in place here. So it's obviously a multi-man woman crew, because you can see here you have.
Ajit, this is not. Just that's it.
Did you flush it? Is this flushed real
well? Yeah, it's flushed.
Okay. Do I twist or?
And does it come in like specific lengths as well, or is just one standardized length?
Yeah, there's multiple lengths. So what length did we go with?
This was a 14 by 34.
Yeah.
34.
Yeah.
So this is
Yeah. So what you do is you marry this with the catheter that your Prograde catheter, which is what we're delivering it through, and then it has like a plastic tube at the beginning. So I'm advancing the coil through it, and now we should be in our in the Prograde.
Yep.
So now we can remove this plastic, and then that will be
that'll be connected to our detachable
to the coil.
system.
Exactly.
You want to go in? Or just we'll do that
at the end. Yeah, once we seat it.
So I think so. This is as you can see, Ray and I are holding the sheath and the Berenstein catheter, but I don't think you're going to make that bend. I think that bend is kinking the Berenstein. As you can see, the coil is coming up now.
Yeah, I think the tortuosity is your biggest limiting factor right there, but hopefully you should be able to get it.
Yeah.
Well, I did one of these, and the key, see, it's not going.
It's not going.
So I'm going to have to pull the Berenstein catheter back slightly, like a push-pull, that'll allow the coil to traverse, hopefully. Did that go? No?
Not going?
No.
Yeah, it's
there.
going.
A little bit of movement, but I guess
Where is it?
Karthik is
It's still there.
still at the proximal end right there.
Can we resheet these or no? Can we resheet this?
It went through.
No?
No.
Yeah, it went through.
Where? I don't see it moving.
I think
I don't
it's
see
still
it.
up there.
It's still up
It's
there.
still
Be
up
careful.
there.
You might poke it
Yeah,
through the catheter.
Yeah. I'm not.
We can always resheet this and then flush the catheter again and see
Yeah,
if that
let's
helps.
resheet this and flush the catheter.
The only reason I'm
The
thinking
bend is
flushing may
coming
help is
from-
because it's not
No,
getting
but now the bend is gone, so
Yeah.
I don't know why it's not going.
and it's not getting stuck at the bend, which is a little strange.
Yeah, because the hypotube is still going there, unless the hypotube is kinked, which doesn't look like it. So
Or clotted.
yeah,
Right. So we should give it a good flush.
especially you're using contrast. So I don't know if contrast made it a little bit more sticky.
I
with
flushed it after the contrast.
Oh, okay.
Yeah. If we flush it and it still doesn't work, then we can try a smaller coil and see if we have better luck with that.
Got
So
it
the
here.
question
I think
is, one of the questions,
Pull
Ajit,
back.
is
This-
can this be
Yeah.
approached from the venous side?
Yeah, I think trying to come in from the inflow is probably a good way to start. I think it can be a little harder
There's
potentially
a
from
lot
the
of
venous
resistance
side.
here.
Okay.
That's
The
what it
coil
is.
is spoiled.
Yeah.
Yeah.
I need-
Yeah,
Can you pull it
Big
back
with
at
the
all, or-
bend. Yeah.
yeah, he was pushing very hard. I think maybe that's why it got spoiled a little bit. I don't know.
Good.
Let's see.
It's still
Okay,
usable,
we got
right?
blood back. We're just flushing it again. All right, we'll try it again one more time. So, guys, I mean, as the audience can see, this is not a simple push and do it. Obviously, you're dealing with a lot of tortuosity. You're dealing with tortuosity in the iliac. You're dealing tortuosity within the fistula, and so therefore, what we're doing is we're just flushing everything, keeping everything straight, and then going forward with it. All right, so
let's
we're
try
trying one more time here.
Yeah.
So, Karthik is working out, so sometimes he pushes a little too hard.
Yeah.
So we need to.
I was trying to do the push-pull kind of stuff.
Definitely not asking Raman.
Can I take-
Forget that; he'll break the coil. Maybe Tepsin or Liz can scrub
I'm gonna
it.
take a new one.
Yeah.
Oh, picking on the injured doctor.
Wow.
Oh,
All right. Let's open up. Let's try 12. Yeah.
yeah, I don't think.
Yeah, I
he's
think
gonna
maybe-
go.
And then
Yeah.
give us the ones that don't expand as much but track better.
Yep. I mean, we can always put the smaller ones distal and then come back.
Yeah.
Yeah,
And then
I
put the
think that's what
larger
it is.
ones
Then you can
proximal,
put it
yeah.
directly
So
through the
I'll
Bunstein,
just
you can put
another,
it in.
yeah. So the ProGrade catheter also, is it like a one-size catheter? Because sometimes if you use a smaller size for a bigger coil, it
It's
might
one.
not be.
I think it's one size. No.
Yeah. No, that's a good point.
Just
The
like an
ProGrade
it's one size.
comes in two sizes.
Yeah, so if you use a smaller size and a bigger coil, it might not fit in proximally. So I don't know what size you're using for
Yeah,
the ProGrade catheter.
Yeah, we went with the high flow, the bigger one.
So yeah, we went with the larger one. Again, I think trying to get as large a coil
This
distally as we can.
Right.
You know, so at this stage, I mean, listen, I mean, for the cardiologist watching, I mean, this is the reason you need to know your equipment. You need to understand the limitations of each equipment and understand how to modify. Obviously, vascular surgery and IR are very well versed with coils, and I think unless you're a cardiologist doing a lot of aneurysms, it's unlikely that you would have worked with all these different coils. Again, it's another great example of collaboration, and we thank Ajit and Peter and Dr. Marin and all the entire vascular surgery department because, again, cases like this, it's the more people you have involved, the more collaboration of equipment, cross-pollination is all good words, so everything will work out. So, Ajit, can you talk through this one?
12.
I think they need another one.
Yeah, open up another one. Yeah. No.
It's not coming out. That's from these
So
calls are very
while we're waiting
hydrophilic.
for the right coil, so this time we tried a 12. We're going to try 12 because it will hopefully track a little better.
So let's troubleshoot, Ajit.
Yeah.
What is the reason why? Now, okay, initially we thought it was a bend. We predicted that. Karthik and I pulled back the catheter, and now the bend is now gone. But yet now we weren't able to track the coil. So what's the reason for that?
I have to say I'm a little surprised because I would expect it maybe not to track through the bends, but it got stuck in the Bernstein catheter before a bend.
Right.
So I wonder if maybe it kind of
The catheter
got some blood on it or expanded potentially before we were at the before we deployed it.
Oh, I see. Okay.
Yeah. So yeah, definitely one of the things is flushing these really well, but
Why don't you flush yours again? Yeah, I think you're right. It might have gotten some blood on it.
yeah. Come here. Pull this off.
Yeah, you can pull it. Okay. And then just pull it straight out. There's big loops. Be careful not to kink the back.
Yeah, that's what happened last time. This got stuck in there.
Yeah. Now it's going.
There.
All right, there we go.
Okay.
All right, now we're in business.
All right, good. All right, so we're going to go again. So the idea for the audience is we're going to try to deploy this, and then we're going to try to deploy a one of the Abbott plugs in proximal to it.
Yeah, I think other options we have while we're sorting this out is potentially some of the other embolic agents we have are glues. So using onyx, things like that. Some people use alcohol,
The
ethanol.
system straight.
Some people use gel foam.
So just as we talk here for the audience, I'm having no support with the Berenstein, so Karthik has to be a little careful.
Take a feel.
Yeah.
I think the biggest thing is to keep the catheter in place because it's going to
Maybe
kick
the
out the
Berenstein got kinked
catheter.
there.
Yeah, it
once
looks
the-
like so, right?
Or maybe the
Bernstein
catheter, maybe you want to pull this catheter a little bit. Let me pull
Yeah,
this a
let's-
little bit. Try it now, Ajit.
It's just getting stuck there.
Yeah,
I think what
strange.
I think what I'll do is I'll
Move the
wire
sheet
with the
back.
coronary
Pull the
wire,
sheet back.
Tiny bit.
and I'll take my ProGrade catheter and probably flush it or check it out. If
No,
you
I
can
think
take
the
a run
Bernstein
through.
got kinked there.
I definitely think the ProGrade is kinked.
Yeah, I think the ProGrade is king. So I probably, if you can use if a coronary wire would go,
Yeah,
I'd probably put it all the way down, exchange it out, check it, and then reintroduce my ProGrade catheter.
All right, guys, give us a coronary wire. Take this out. So give me the run through back. If the run through doesn't go, then we know that's it.
Yeah,
So,
exactly.
Ajit, do you think Bernstein, even if it kinked, it'll be big enough to directly take the coil in?
Thank you.
I mean, my guess is it's probably the ProGrade, but
Yeah, I think it's
So-
the ProGrade that's acting up probably.
Well, remember, I mean, it was quite tortuous. We were pushing
Do you
on
want to
it.
take an
Karthik and I.
overnight? Do you want to take an overnight
We
Trailblazer?
might. No, Trailblazer
Got
won't
it.
track. This barely.
No, that's
track.
not going to. Yeah.
pull back a little.
So I think, in fairness to the ProGrade, I mean, we were treating it like, how can you say? I don't even know what to say. Something.
Not very well.
Something that's clean.
Yeah.
It's very hard for me. I've been reprimanded by
Yeah.
Elizabeth many times.
The fact that it's getting stuck at the same place
Yeah,
twice.
I think
that,
it's
it's
So
gotta be something
Karthik
with
is
it.
just going to push this wire down, and then once hopefully this wire will go down. If not, I'll just track my Berenstein
down
over the
and then we'll
ProGrade and then
rewire
pull the ProGrade out. Yep, coronary
so this
stuff
went
goes-
through very
this
well.
went through. Okay, push. That's fine.
Any other
That's
reasons?
fine right there. Let's just track the Berenstein. No, not that. The
We're
Berenstein.
using the larger ProGrade. That should be fine, right?
Take
Okay,
a little
now I'm
bit more
gonna
down,
take out
PK, and
the
see.
ProGrade.
Take a little bit more down with the
I'm just going
Bernstein.
to take out the ProGrade now.
Easy. The wire is
You
coming
want to
back.
give us a 2-4?
No, you still have the wire, PK.
No, the wire is stuck to the ProGrade.
Okay, that's fine.
Yeah, I think it's the ProGrade because the wire is stuck
I
to the
just told him to
ProGrade.
open up another one because
So now give me another wire here, guys.
We'll use the same wire.
Yeah, I just got to pull the. No, I'm going to have to use an 035, I think. We'll see.
the other option is we could just use 035
Catheter to
coils
push it
too.
in. Yeah,
you
just
know,
to
because
directly through the
we
Bernstein.
have-
But you look
Bernstein.
what happened to the Bernstein. It's
Yeah,
kicking.
but it's
You want to take
It's-
a stiffer catheter?
Yeah, there's a kink right here.
I think we'll probably exchange for a new ProGrade because the Bernstein is a little bit more proximal. You would
Okay.
probably want it as distal like Ajit, like you guys talked about. So I think the ProGrade still gave us a little bit more depth in the system.
When the ProGrade
So.
is going through that bend,
You got
it's got kinked.
nobody. That part
problem.
never went through that.
No, I'm
Yeah.
saying when this
the
time the
bottom
ProGrade
right
is
here.
going through, pull the Bernstein back, PK.
If you
Or put
want.
it over an 035. Over.
Interesting.
Yeah. That's it. Above 200, 250 is okay. Just like regular.
Okay, let's leave it right here for now.
Yeah, because we have an 8-inch sheet.
Okay,
we want
I'll leave it right now. No, go. Let the ProGrade go through that. Do it fine.
Yeah. Push up wire a little
Alright,
bit.
No,
yeah.
look, once the ProGrade goes through, you can wire it easier.
Yeah, we have a new ProGrade now. This one comes with a wire, so
You just take it out.
yeah,
now.
take it out. We don't need it.
So again, now again some technical
first.
issues going on, but again these are challenges. So now we're going to go with this, and hopefully we'll be able to deploy a couple of coils, and then we'll deploy the
when
plug.
the Bernstein was in, probably when you're pushing, trying to push the Bernstein in.
Yeah. But I think this brings up a good point: is you should have multiple options, and we have other ways we can treat this, and we're, like we said, having access well into the malformation gives us more options. So.
Yeah, wire.
But I think the issue is mainly the prograde, so hopefully this will fix it.
I hope so. We'll see. You ready? Just watch the wire distal, Roman.
Yep.
All right, now we're going with this.
Coils.
Trying to be as smooth as possible.
Okay. Can we just grab some ones just in case?
No issues crossing the Bernstein. No issues.
I think this time it will be better. One second. Come on. Okay. A little bit more.
No, you're just circling there.
Yeah, that's it. I just want
It's okay. Take it
to be deep in. Take it.
The more, the better, because it'll be easy. If it comes back, you'll still be in.
Good.
Okay. Good.
That's good.
All right.
It'll give you more support if it circles, actually.
Okay, we'll try this now. Let me flush it.
All right, now we're going to flush it, and we're going to go.
But at least today, PK can't blame me for being at Kinked and not going through, so I'm happy about that.
Honestly,
You're not sure about that.
I never.
I'm not sure about that. Excuse me, Raman. What again?
Actually, the audience has emailed me multiple times.
Actually, you said pull back and push, so I think that's what King did. So I think it's still you, but
it's still you. But the audience has emailed me multiple times, Vishal, about how you always try to undermine the cases.
I appreciate the team effort.
Put the wire under your feet.
They're like, Dr. Kapoor makes it so exciting.
He shows us all the complications.
Ready? All right, here we go. So, okay, again, I know this is sort of watching paint dry. What's going on distal with our catheter there? Just coiled up.
Just coiled up.
It's going easy.
Yeah.
Okay.
So, I think at this stage we're going to go ahead. Hopefully this goes through. And if not, we'll have to decide what else to do. I mean, it should go without a problem, is what I'm thinking. No problem. Okay. All right, Ajit. Now you're going to have a problem here. See? So the question is, do I pull the catheter, push the coil is the question. Karthik is trying that, not going. See, that bend is so acute, Ajit.
Yeah, now it's getting stuck
There
to the
you
tip of the
go.
catheter.
All right, now hold on. Let's decide here. Ajit, what do you think?
I think we're in a good position.
Okay, let's go. So
What I will try to do is track the Bernstein over to see, because now you have support.
No.
That will support your renegades.
Let's leave it there.
Okay, hold on. Let's see. Ajit, you want to deploy the first one? Show us how to do it.
Yeah, let's first get it deployed.
Yeah.
Where's our tip of our microcatheter?
It's all the way down. Mag up, Raman. Hold on a second. We're going to mag up now, and we're going to go on better flora. Can have higher quality flora. I know we're going to get radiated a little bit. Ready? Okay, let me hold on
Mag
a
up.
second.
The coil right now. Coil's at the end of the prograte, right?
Mag up, Raman.
Okay.
One more. Okay, you see the end of the coil is at the end now.
Okay.
It's out now.
It's out.
So, yeah, let's fully take it out.
Which one?
Let's fully make a coil mass with the,
Okay.
and then we can detach it. I just want to make sure it sits.
That's your coil mass.
Where's your Bernstein? There it is.
Bernstein is back.
Yep.
It's just coiling in.
Where's the prograte? I'm still having a hard time seeing the tip.
The prograde tip is right there. So if you move it, PK, right behind the coils.
Okay.
Yeah, but I think you're not out of the.
It's the bottom
program.
of, I think so too.
Hold on.
The coils are already making it. See, those are all coils. The prograde tip is right here.
So the coil is definitely outside.
Prograde tip is right there.
Okay.
Those are all coils.
The prograde tip is at 12, 11 o'clock.
Watch your knees.
Those are all
Yeah,
coils.
so what we want to do is just take the coil fully out of the prograte, and then we'll deploy it once we're happy with the position.
Give 500 more. Are you in the right spot?
Yeah, I'm in the right spot, PK. I'm just coiling. This is all huge vessels, right? So it's all just coiling in there, in that one spot. See that? Like a ball forming in there.
Yeah, we're going to need a lot of these coils.
We're going to need a lot of these coils.
Yeah, see, the prograde tip is at 3 o'clock. So.
Yeah.
Okay, there's the coil. That's the end of the coil tip.
Yeah.
Okay, so now I think
it's completely
fully
out.
So we can deploy.
Okay, hold on. Let's see how we deploy.
Let's see how you deploy it there.
Yeah, so first off, we check and make sure. I think I'm pretty happy with that position.
Want to take a picture or no?
Yeah, let's take a picture.
All right, ready? DSA, Roman?
So your prograde is
Ready, brother?
Focus on what he's doing.
DSA. Yeah.
Okay, ready?
Raman. Yeah.
Here,
Jack.
open up another 12. Yeah.
Let's look at the screen. Yeah, the monitors.
Oh yeah. Okay. Beautiful. Yeah, so
we don't see the screen. 1 second, PK. Can we see the screen back again? Yeah. All right. Perfect. Okay,
yeah, so
great. Yes, thank you.
Yeah, so it's calling up right at that bend, which is why it looks that. But I think it looks good. It's we're gonna definitely need a couple.
Yeah.
So I think we're ready to deploy this one. So how that works is at the end of your coil, the wire that we use to push out the coil, we attach this device here. And then it will give us a green light telling us it's ready to deploy. And so we just hit the button.
Let's see Ajit's hands if we can. 1 second.
Wait 1 second.
They're
Can
just
you,
trying
can you
to-
show his hands
Can you
here?
show his hands, please?
His hands?
And let me see if I can get it on the screen here.
No, he'll
Yeah, bring it this
there
way.
you go.
Yeah, that's better.
Yeah, so
Let's
here's
zoom in.
here's the device, and then here's the green
button.
light. This tells you that it's
and
good
there
to
is
go.
a button there.
And so you just hit this button at the top. And
Push it there and keep it there.
yeah, let's try that again. So you should hear 3 beeps.
Beep, beep, beep.
Issues you can run into are if there's blood on the end of the tip.
I think there is.
But is it detached or no?
No, you should
Not yet.
hear. What's the issue here?
We'll try another one here.
Yeah, just building up the suspense, I guess.
Yeah.
All right, let's see.
There you go.
Yeah, my lord.
All right,
Coil
that's,
change.
that's the sound you want to hear.
All right. So
All
it's
right.
not detached.
So now it's attached, but just slowly pull back just to make sure.
And the Renegade will go in as.
Well, you're attached still.
Yeah, you should be detached. So as long as nothing moves significantly, we're okay.
It's detached.
There you go. Beautiful. Oh, that's exciting.
That's the good one.
I'm really excited. That's
Let's
awesome.
not throw it away.
All right.
Like, wow.
So
No, I'm serious. That's cool.
Yeah.
I mean, back in the days, you'd have to push with a back end of the wire.
We
That's
still
all.
do it for Coil.
I
It's at the
know.
back end of the wire. So
Yeah. So that's why you just have so much control. You know, if it didn't pack well, we
yeah,
can
one more.
pull it out and do it again. Did we open up another 12?
So how many of these we're doing?
As
think-
many as you can.
I think we're going to need a few
Okay.
to really pack it well.
All right. So let's open through 2 more guys quickly.
Should we go through the rest of the coils while
Yeah.
we
Okay.
we
So
do this?
so as we're
Yeah.
doing this stuff, Raman G is going to go through some of the stuff for us. Let's go.
All right, slides, please.
So one of the comments.
All right. The next up, we're going to talk about some of the coils that are available on the market. So the Concerto Medtronic coils come in 2 flavors. They have a Versa and a 3D helical. The Concerto Versa itself comes into 2 separate shapes. One is a multi-sphere shape. The other is a sphere shape. And the concept is quite it's kind of elegant. Depending on the sphere shape that you choose, the first shape may be oversized to adhere to the aluminum wall, and then the rest of them kind of just pack behind the first one, and those come up to millimeter size of a 14. The sphere, the entire sphere shape, the first one is actually used as a smaller loop to help conform to the actual shape of the 3D structure that has to be filled up, and then the rest of them kind of form other large loops in order to actually fill the entire space. And the way these perform the thermogenicity is that this is actually all the coils are based off some form of metal, either platinum, usually it's bare platinum or a steel core, and they have some thermogenic factor, whether it's a fiber, it's a Dacron graft, or a PGLA filaments, versus the Teruma ones, which actually have a hydrogel, which we'll talk about in a moment. And these coils they're all very soft, and with the distal delivery catheters, they can get quite far. Obviously, sometimes with some technical difficulties, but the way how they're released is by a ball and socket mechanism, and we'll talk about that in a second. The 3D detachable coils, again, very, very similar, except the idea that's different about them is that the first loop is a very small one and allows for a 3D anchoring into a irregular 3D shape. So some sort of like a berry aneurysm would be very useful here. To be used as actual device to treat it. And you can see in the image on the right, the first set of coils kind of configures to the entire circumferential space, and then the rest of them kind of fill in the remaining space, like one of those Russian dolls, as Medtronic advertises. The interlock IDC detachable coils also come in a number of flavors. These actually are again platinum wires with Dacron fibers attached to them. They have 035 and 018 wires for the small to large, and they come in different sizes, a 2D helical, diamond, and cube, each of them serving a different purpose. The 2D helical is useful for in a vessel that has to be closed, and it allows for a constant contact within the actual vessel wall. The diamonds are very good for capping the proximal distal ends, and in this particular case, we're likely going to be using a plug as opposed to this. And the cube, again, can be used for large 3D structures. The Terumo catheter, the one that we're using here, is the 24CX, just the prograde the coils. Yeah. Yeah, the Azure CX. So we're using the Azure CX, which is the third one down here. Again, each of the coils, the way how they're constructed, each conforms to a final shape that then results in the appropriate anatomic coverage to achieve a successful occlusion. And they were actually using the prograde catheter to deliver it in this particular case. As I mentioned before, the different types of coils and what the technologies are. The first coils that really ever came out were just simple platinum-based coils. After that, different forms of fibers have been attached to these coils to promote thrombus formation, whether it be nylon, PGLA, or Dacron that was with the interlock. The Terumo ones actually have this Expansa hydrogel that promotes natural tissue growth, and that's what we're using in this particular case. And then there's a whole set of pushable coils, which we're not using in this case. This case, everything we're using are detachable coils. This is a whole different set of coils. We use these very often in the coronary world. And this is a video of a coil deployment. This looks like it's, I think, the Medtronic coils. And again, similar concept. Once the vessel of choice has been accessed and the catheter is in, the coils usually come in a pre-deployed catheter system that's then advanced into the mother and daughter hypotube, and then that exits the distal port of the microcatheter or diagnostic catheter to then eventually be released into the selected vessel. And a lot of these, as we even demonstrated here, these coils are extractable. So if you're unhappy with the position, you can actually pull everything back. And once you're finally okay with the position, you can continue to deploy it. And the way how the Medtronic one works is a ball and socket kind of clasp, and you'll see that animation in a second. At some point, here it is. A separate detacher similar to this Terumo detacher. The mechanism is a little bit different, but eventually the end result is that the coil is detached. And it's not uncommon that multiple coils have to use combinations of clips, coils, clips, plugs, all that stuff are also used. Just a side note of something interesting that I saw. There was a case that was published a few years ago that actually used an ASD septal occluder to do something very similar to this exact case. But this was a traumatic internal iliac artery fistula that had a single fistula with a size of about 4 to 5 millimeters. And they actually used a ASD septal occluder to achieve what we're doing today. So again, there are a lot of things in the armamentarium that could be used. Dr. Rao was mentioning plugs, glues, and other types of alcohol, things that can also be used, but there are also even some off-label uses for Amplatzer septal occluders in this particular embolization procedure should the anatomy be forgiving to allow it.
Connection. We're in the right connection. We're lucky there's only one connection.
Yeah, definitely.
Okay.
Yeah. Then go back up.
Okay, so if you can, while Raman was doing that, we went ahead and deployed this. This is the coil.
No, this is the grade. One second.
What is it?
I'll give you another one. This is a program wire. Put this in.
What wire was that?
The ProGrades wire.
Oh, okay.
Put it in.
So we now deployed a ball of coils, about 4 coils in there, and now we're going to go ahead with the coronary wire into this, and now over the coronary wire we're going to put back the ProGrade and then go ahead and deploy a bunch more coils. What happened to my pressure, guys? Raman, can you show me the last picture?
Yes, with pleasure.
Hydralazine. Okay, good. So you can see here there's still flow, which you would expect, but the whole idea here would be to put more coils in. The patient is heparinized, ACG is around 250, so we're going to go ahead and continue to put more coils, and then at the end put a plug, and hopefully that'll end it. So what are the options now? We do all this, it doesn't close. Can we come from the venous side as a second step?
Yeah, so I think since we're heparinized, kind of one of the things we have to potentially accept is that there may still be flow through it. And as long as we pack it really well, which we already have, but we're going to be extra sure, but we may still have a flow through it, which, won't be unexpected because we're heparinized. Okay. And I think even with the plug, that's going to give us some added security. But yeah, so let's say we do this and then we do the plug and it's still, open on a post-op CTA. I think your options are either to try to come back and try to get around that coil mass or the plug, which is going to be hard, but possible. I think you potentially can come from the venous side, but truthfully, I just haven't had much experience with it, much luck with it, so I don't know if.
So what are the challenges of coming through the venous side? Why can't you just plug it off right at the internal iliac vein on the venous side?
Yeah, I think one of the issues might be, especially if she has pelvic symptoms, is you still have a pressurized, venous system in there, even if there's no outflow, and there might be some small branches, in some other areas. So you may not fix the problem, and then you kind of, if you plug it right at the outflow, you're not going to be able to get back in.
Got it.
Yeah. But hers is more heart failure symptoms.
Yeah.
So potentially just getting rid of that connection could help. But I think this is definitely the right move, is to do the arterial side first.
So should we have worked harder in getting the coil further distal, or you think this is enough?
I think we're pretty well distal. And I think this one, thankfully, only has, at least right now, I can only see one main connection. So I think that makes our chance of success much higher. So I think
I think it's a huge fistula. So that's why you still haven't seen much of a change. But yeah, a lot of coils would be probably needed to really see that occlusive blood flow through it. So I think we'll still have to work a little bit harder. But yeah, watch your catheter.
Yeah.
But I think that's actually a good sign that we're having some issues packing this, because that means it's packed pretty well. So this may actually be our last one, depending on.
Yeah, definitely looks like so, because I'm seeing.
Yeah. Because basically what you want to see, especially for these really large ones, is you don't want to see any gaps in the coils. Kind of want it to all look, really opaque and black. So I think we're pretty much there now. Hopefully we can get this last one to track.
Oh, no. The other option you might see is probably use a smaller length if that helps, but I don't think in this case, because everything is backing up as soon as it started. So,
yeah,
it's a good sign though, actually.
Yeah,
it's almost there.
The question is,
Still okay.
Yeah, even if there's a little tail like that, that's okay.
Hold on,
your ProGrade catheter. Yeah, exactly. Yeah. It's a little bit too.
Yeah, that's perfect.
And I think this is why having good support system is really key, because once you get to this point, things will start buckling out if you don't have like a long sheath, a Bernstein catheter. So that's why you really need the support system. Because if we were in the aorta, for example, this could be treacherous.
I like this one. I think this might be our last one.
System.
I like this pack.
Okay.
How often would you do these from the ipsilateral side?
I think in this case, Roman, you have to because of the angle of takeoff. It'd be very tough.
IPSI.
Oh, IPSI. Yeah. Oh no, I think
very
depending on the angle.
engage.
I think depending on the angle of takeoff.
Yeah.
Yeah, I think it'd be easier coming up and over, just because, like you said, the angle. You'd have to make a reverse curve catheter to get into the hypo. All right. Should be deployed.
I think here you can now put a plug, PK.
All right, let's see what it says. So I'm going to walk this out again and take another picture.
Mm-hmm.
All right. Okay.
So I guess the other question I have is just, do we need a plug, you think?
That pressure is really low now.
Yeah, that's the real question.
We definitely have room for...
No, we have a lot of room for more coils, but
No bleed or anything.
So the question is, why is the pressure so low? Okay. She's not tacky, so it's a good sign.
Just dropping her pressure with the hydrolysine, that's all it is. I will put
Yeah,
a
so
plug
I
here.
think just because there's still pretty brisk flow, it's not unreasonable to place the plug just to make sure we have it tightly packed.
Right in that coil segment, just
Yeah, if we
push
can get it
into
at
the
that
ball,
bend.
Yep.
And then
All right, so what plug do you want?
So we're going to use an Amplatzer plug.
Yep.
So the vessel measures about 9 or 10, I think, at this area.
Liz,
So we want to oversize, I believe, 30 to 50%. So if we have like a 14 plug, that might be good. Do we have a 14 Amplatzer?
Let's do another picture from another angle.
so you want to
And if I remember right, that we need the 8 French sheets. So do you think we could track that any farther in, or?
I'm just want to, yeah, I think you can. Like, can I have some direct? So I just want to take one more picture on this angle here, just to make sure we're not.
so you want to take a low mag picture, just low mag.
Well, one of the things you worry is that when you're pushing these wires, that it break through a vein, and is the patient?
No, that's what I'm
bleeding?
saying, a low mag. That's why
Yeah, you can do low mag.
Just to see.
Yeah. You can. It's fine.
Okay.
All right. So there's again another reason to have a bunch of eyes on the case, right? To see what's happening. Well, I don't see any bleed. Do you?
No,
No.
I don't see any extra.
Yeah.
I think it's probably just hyper. She's responding very well to me.
Yeah,
I think it's
she's
just probably because
yep.
the hydrolysine delayed response.
Yeah. So you can tell, you can see, guys, that we're in the right vessel here. This is the feeding vessel. So you've really gotten the vessel in the right area.
You want to put it through the 035?
So what would you like to do?
So if possible, it would be good if we can get like the sheath all the way down to that coil mass or
So
close.
now I need us to give Ray, I need a woolly wire first. So we're going to start with a woolly wire. I'm going to track the Berenstein all the way down, close to it. Then I'm going to switch out for an Amplatz super stiff with a 3 centimeter tip. And then I'm going to go closer.
Yeah, just because that way, if we do that, we can deploy the plug right through the sheath, which will be the easiest way to do it.
So Liz, I do want you to know there has been quite a bit of oozing from my catheter here, as much as Ray and I have tried not to do it. Ray, I'm going to need your help because my I got it in. My eyesight has not been the best. What?
So the other thing to mention is, so the Amplatzer plug we're using is a 14. And so they have 2 Amplatzer plugs, 1 and a 2, and one of them is a bit, it's almost doubled.
Now
so
give me the
there's
Amplatzer.
more material in there,
The Amplatzer wire?
which they think potentially can make it,
more.
Yeah, I have it.
The downside is it,
14.
Obviously harder to pack. So in this case, we went with the one that's easier to pack because it's going to be pretty hard to get it into that bend. And we have that coil mass already in there, so I don't think we need to.
Through a whole bunch of choices. Obviously, there's some great technology out there. Ray, fix both, buddy. Question is, what's the situation in the choice of plug, and how do you choose? Thanks, buddy.
Yeah. So my familiarity is with the Amplatzer plug, so that's the one that I most commonly use. And I think kind of my experience with that has been you really need to oversize it well.
I'm going to push pull.
At least 30 to 50% for it to be effective.
Let go there, Berenstein.
And then the other thing that I've noticed is it won't. You may not have it thrombose off immediately.
Right.
It may take time. So like, it's not the best option to use in a, if you have a bleed or anything like that. But in this case, it's perfectly fine because we don't need this to thrombose off in, the next couple seconds. It's okay if it takes a day or two. So.
Yeah, that's what I was going to say. Sometimes even if you see some flow, you just have to give it a bit of time for it to settle in. So you might repeat a CTA, in a few days or so, just to see how the fistula is behaving. So.
Right.
Test on the.
But I do like it because I think especially if you have your sheath where you want to deploy it, it's really easy to deploy.
Further down a
you just.
He wants to enter into the mouth of the fistula, I guess.
Yeah, if you can, that would be ideal.
Okay.
It's really decent. A little bit more would be okay, 2 PK. It can take it. The vessel is pretty big. Yeah, puff a little bit, no?
I think the Bernstein gives a good rail.
That's good.
Okay, ready? I'll fix that, Ray.
Still, huh?
Sorry, Ray.
Yeah, because ideally I want to...
Okay, I'm going to leave the Amplatzer down, right? The sheet, the wire down?
Yeah, and then can we take a good picture from the sheath just so I can see where the start of it is?
Okay, let go, Ray. Uh-huh. Go back RAO now. LAO, I'm sorry.
Watch your legs.
Uh-huh.
Ray, watch your legs.
Okay, center it. Yeah, ready for DSA? Ready?
Mm-hmm. You're actually in that whole thing.
Mm-hmm.
You want me to advance a little more?
I would not.
If you can get all the way down to the straight back.
Yeah, I think that'll be a good idea.
Okay, Ray, fix the sheath, Ray.
It might actually. PK, 1 second.
What'd you say?
No, it's right in the mouth at that fistula. Pushing a little more might.
Oh, you say? Okay, yeah. If it doesn't go, it's not.
I would not pick it.
Yeah, okay. I agree. It was a lot of resistance when I was pushing.
I would not.
Okay, so scene minus.
You're already selectively into the fistula, so I think it's pretty reasonable.
So, you're definitely in the fistula.
Yeah, I guess my question is how far in are we into the fistula?
I think the mouth starts on the top.
Because I just want to make sure if our plug doesn't track well, we can just leave it where the end of our sheath is.
We're going to have to advance this catheter quite a bit.
Yeah, we can put the Bernstein in and then pull back the sheath and see if we can.
No, I don't want to do that again. I don't want to lose my position.
Yeah, the position is
the previous shots.
Do we have a prior shot?
Yeah, we have.
Just to get a sense of it.
Came back, I think, already.
So this is one of the reasons why we, went well into the fistula. So we have room here, which I think we have plenty. I just want to double check.
See in minus? Minus?
What about that one?
This one I think we'll show you. No, minus? Yeah.
Oh, yeah, we have plenty, right?
Yeah, a lot of room.
Because we're...
Yeah. About the bend, you have at least 2 centimeters.
Yeah, so I think we'll be okay.
Okay, so I'm going to leave the Amplatzer wire on. Ray's going to fix the sheet.
I think the sheet came back a little bit.
No, a little there?
Definitely came back, 100%. Yeah, you did it. Sine?
It's just kinked a little bit. Once it straightens up...
It's just kinked.
Yeah, it'll straighten up. It'll selectively engage
just
into
definitely came back. You're now into the... definitely came back because you want to push it in a little bit with the Bernstein.
No.
Definitely came back, 100%.
It didn't come back. I pushed the wire.
1 second. 1 second, off. Okay.
Oh.
I probably straighten the system and track it over, yeah.
Yeah. That's it. That's good.
Beautiful.
That's good. That's even more better.
Okay. Yeah, that's plenty.
That's it.
Fix that, Ray. Look at the pressure now. That's the problem.
Yeah.
Well, the pressure because there's no flow.
Into the venous system.
Yeah.
So.
You already
want to just go with the... You want to go with the non-invasive, Liz?
Yeah.
No, that's because it's in the fistula. It's right at the bend of the fistula.
So we can take out the wire and then we can load this on.
Do you want to take a picture?
Yeah, we can take a picture. Just
okay. Ready, Roman?
Just go low pressure, Roman. Yeah. Very, very low. Yeah. Yeah, right.
Beautiful.
That's why it's in the vein.
Yeah. So at this point, we can literally just unsheath the plug once we get it all the way down.
Go ahead. Show us how it's done. So, talk us through it, brother.
You want me to hold the sheath?
Can you zoom into his hand? Yeah, 1 second. Ajit, we're just going to zoom into your hand, try to see if we can get a visualization right there.
Yeah. So this is, like I said, the Amplatzer plug. So it comes on a wire, and then at the end...
30 seconds. Cycle every 30 seconds.
Can we zoom in? Hold on. Can we zoom in?
Yeah. So at the end of the plug is a plastic... yeah, is a plastic piece, and so the plug is unsheathed and sheathed into this. And so what you do is you place this plastic plug directly into the delivery system.
Ajit, let me show this here.
Yeah, so show it here.
No, Karthik, they're zoomed in right there.
They took out one of the cameras. Okay.
Yeah, here we go. So you can see pretty well here. So here's the plastic sheath, and our plug, if you can see it, is right in the middle.
Okay.
And so it's attached to this wire. So how you deploy this is once you're in place, you turn it counterclockwise, and that will eventually it will detach from this wire. The other things to consider, you really want to pack this well. Okay. So as you'll see, when I'm here, I'm going to try to pack it and just kind of crush it as much as I can. So now we're ready to go because our sheath's in good place. So I advance it through our sheath, and then I advance the wire.
So you push it through it that way. So
yeah, so our sheath is, in this case, our sheath is the delivery system.
Right.
And then,
can we put it on coronary, guys, so everybody can see? Or high fluoro, whatever the best fluoro is. You know,
And then I'm slowly advancing my plug here. You can see it coming from the other side. And
I'm on the high floor.
Perfect.
It'll be coming down
All
now.
right. So you can see now there's the Amplatzer plug.
So it looks initially, it will look elongated because it's obviously in the sheath. But once you start deploying, and I can take control of the sheath, you really want to try to pack it. And so I think that sits very nicely. It actually took that bend, which is what we wanted.
Yeah.
So now we just have to release it. So there's a torquer. Yeah, it comes with its own torquer. If not, we can use like a hemostat, and we just rotate it counterclockwise.
No, 035.
We just rotate it counterclockwise, and you'll see it kind of release from the wire.
Oh, was I not supposed to throw that torquer away?
Or a hemostat. Don't ask me how I know that.
Oh, God.
Raman knows me too well. He's laughing because he knows it's true.
I have another 035. Luckily, we have two.
I got it.
I'm
joking. You want a hemostat?
Yeah.
Yeah.
No,
Or did you find it?
035 torquer. Right there.
Doesn't surprise me.
So can someone hold the sheet
right.
for me?
I got it.
Thank you. And so I'm just rotating this counterclockwise.
Okay, let's fluoro save this, guys.
Or do you want to do this on Cine, or is it too late?
Save it, yeah.
And hopefully this will detach. Yep.
Detached.
Okay, fluoro save
Okay.
that.
So I don't know if you saw, but there's a part where it kind of shifted, and that's when you know it's detached.
Okay, so now let's take this out and take a picture.
So that looks pretty good.
I think we can take a picture even with.
Yeah, and so the sheath is still in place, which is another nice way of doing it.
Ready? All right, let's take a nice cine.
Wow.
So should we put another one on top of that? A bigger one?
I think, truthfully, this is going to thrombose off between all those coils and the plugs.
Perfect.
The reason that, I think it's obviously still flowing is just because of the heparin. So it's going through all the crevices, but, I'd be really, really surprised if this stays open.
Okay, so we've closed off what we think is the main branch. What else can we do now to make sure we haven't missed anything? Because it looks like everything is flowing through this.
Yeah, I agree. I mean, I think it looks like this is the only other things to consider are just trying to select the other branches, but I think we did that in the beginning, and selectively catheterizing all the branches to make sure there's no other connections.
So why don't give me the Berenstein catheter back? Let me walk this back, since we don't need this at this stage, right?
And like I was mentioning before, the Amplatzer plug takes time to thrombose off. That's the other reason why I think we'll be just fine.
Well, the Amplatzer plug is a cool device. I mean, we've used it in TAVR issues. There was once when the subclavian conduit, obviously failed, and there was bleeding into the thorax. And and I think in that case it was me and Dan. We did a Amplatzer plug into the subclavian, connection, which really worked out really well.
So let me ask you this. I mean, I guess me and Shreya was talking about this case yesterday, and I guess the other question is there any role of using a covered stent across the internal iliac in this case?
I got it. Just roll.
Ajit, what do you think?
Yeah, I mean, that's definitely something to consider. I think that's kind of your last ditch effort, because once you do that, you're never going to be able to really. It's going to be really hard anyway to get back in. But I think if this was a bleed or something like that, and we needed we had no other options, I think placing a covered stent over it is definitely.
So now the question is, you see those two little branches there. The question is that another communication that we're having?
But I certainly wouldn't do it in this case.
No, we'll bring her back.
I guess
this might be enough to, obviously,
to start the process.
Yeah, exactly. So let me just pull this back now and try to just have Raman take another good big picture here.
Yes, I think it's a good idea. I mean,
I think we're going to stop here for at this stage and see how she does, and then we'll bring her back. I mean, obviously, this is the major connection.
Right.
This is it.
I think we nailed the right vessel. It just probably takes time to have a thrombogenic effect. And then we can repeat probably a CTA soon and then get an idea of how it responded.
Agreed.
What do you think, Ajit? I think this is it, right?
Yeah, I don't see anything else.
I don't see anything else. This is it. So she's very lucky. I think we did a great job here, and we demonstrated it. So in terms of, I guess, follow-up for this patient, do we put her on Plavix? Do we not put her on? Obviously, she's on Plavix for the coronary, but beyond that, I mean, if you did this as an isolated case, what would you do?
I think, yeah, just even aspirin or something like that is fine because, we want this to thrombose off, so I wouldn't be super aggressive with it.
Right. I mean, yeah, and the whole idea is that, and this is probably one of the few times in cardiology or vascular where you like clot.
That's true.
You're like, wow, I actually like clot here. One more time. And I'm just doing my due diligence here, just checking, make sure we didn't create any trauma to the internal iliac artery or anything. So I'm going to keep coming back here, keep pulling back, and just have Raman just keep giving dye, and maybe at this stage right here.
No, you're in the Raman.
Okay. It's definitely slowed down a lot.
Yeah.
Definitely.
So I think we'll be fine. So I think with this now, we're going to seal up with an angio seal, and then we're going to be done with this case together. So I want to thank Dr. Rao. Really, honestly, he took his time today for being here. Thank you, Ajit, so much.
Yeah, of course. Thanks.
It was just an amazing job. And Raman, great presentation. So we're going to close up with an angio seal here. And Vishal, I think with that, we sign off. Thank you so much for all your advice as well.
Thank you so much. Thank you, Dr. Krishnan, Dr. Guja, and a special thanks to Ajit for joining us today for a great collaborative effort here at our endovascular case. Hope you guys enjoyed the case for an exciting educational strategy. So what we're going to do is June 23rd for our next live case presentation from Mount Sinai Hospital in New York, Eastern Standard Time, 8 o'clock. Till then, enjoy the start of the summer, and we'll see you next month. Thank you.